All right, everyone, good morning.
Good morning.
So my name is Arifa Bevan.
And I'm Christopher Zapiri. How's everybody doing?
Good, how are you?
And today we're going to talk about ED usage, not just ED use, but avoidable ED usage for your clients and patients. So before we start, I just want to tell you about my role at CDPHP, and then Chris will go into his role, and then maybe we just go around the room and learn a little bit more about what you all do and where you're from. So I work at CDPHP as a community engagement advocate. My role is to work with members directly and assist them with getting connected to care. So I am out in the community the majority of the time trying to engage members or find members who otherwise would have a hard time getting connected to care. So I work with our homeless and Medicaid population in addition to Medicare and commercial as well. I teach health literacy classes in the community too. And so I connect members to services such as Chris for case management, whether it is medical case management or behavioral case management. Members do get to work with me directly if they do not have a chronic condition or a behavioral health need. So if they need something as simple as a new ID card or a billing question or recertification or help with simply finding a primary care doctor or a dentist, then they work with me directly.
And I'm Chris Zapiri again, and my role at CDPHP, I'm the manager for our care management and our Medicaid long-term services and support programs. I've been with CDPHP for 10 years. Our team is comprised of nurses as well as social workers and licensed mental health counselors. We also have some certified diabetic educators as well as asthma educators. And our job is to really work with our members from a case management perspective to work on any needs that they might have, provide some educational support, also provide resources for community support, and link those members to those appropriate resources. So we have a staff of 54 that do all lines of business. We do Medicare, Medicaid, and our commercially insured population. And so really, our job is to support our members to help them through the continuum of the convoluted, confusing healthcare system and make sure that they get the care that they need and the quality care that they need. And work with community agencies such as yourselves because you're working with our members as well. So we're excited to be here today to talk about the ER usage and how to avoid some of that, and I'm really excited to meet all of you. Thank you.
So thank you for having us. I think I'll start with my right, and I can get your name and where you're coming from.
Amanda Lyons, Green County Mental Health. I'm the Director of Fiscal and Business Operations. Francesca Dicerni, Green County Mental Health. I'm the clinic nurse and the psyche project, do it all, and that's a lot of things.
My name is Cheryl Tracy. I'm an RN case manager. I work at Saratoga Hospital in the outpatient facility at Wilson. We have just started our program about a year ago, a little over a year ago, with outpatient case managers. And I work with 12 providers, and it's a new program, and we're eager to learn. Great.
I'm Brenda Little. I work with Cheryl, but not in her facility. I work in the Mechanicsville office of Saratoga Hospital doing the same thing.
I'm Barbara Rogers, RN Care Manager at Oldendorf Medical, local primary care office. 6 providers and a small care management team.
So do you know Kathy Canoni?
I do.
So she's one of the nurses on our case management team.
She's embedded in our office. Yep.
Good morning, everybody. Excuse my voice, I'm a little under the weather. My name is Mercedes Arriaga. I'm from the Alliance for Positive Health. I'm a program manager for Population Health and District, so I'm working on a bunch of different initiatives for District and general population health as a whole.
Good morning. I'm Nikki Tanksley. I'm with Trinity Alliance. I'm Catholic Charity Tri-County Services. I am the Community Resource Navigator.
Hi, I'm Joyce Johansson. I'm the Program Director for the Outpatient Clinic at CDPC, Albany Community Support Center.
Good morning. I'm Marissa Reynolds. I'm the Program Director of the Child and Adolescent Outpatient Clinic, also at CDPC.
And I think we have someone in the back that just came in.
Thank you. Allison Wagner with Healthy Capital District Initiative, and I'm the Director of Enrollment Services.
Wonderful. Well, thank you, everyone. A lot of this information you all may already be familiar with, perhaps not familiar with, but if you are, maybe it's a refresher. If you're not, wonderful, but we do hope that you can learn from today's session and maybe even bring it back to your staff as well to share. So please don't hesitate to ask us questions as we go on throughout this. training or, share some of your own stories as well from your own experiences. Oh, that's good, Sarah.
She gets that pulled up. So the next slide is really talking about what the problem is. Really that is a lot of patients will use the emergency room for their primary care office, essentially. So you're, a couple things are happening. You're clogging up the EDs, which maybe for not appropriate usage. And you're also not linked to somebody who should know your healthcare the best. So really, and there's multiple things that kind of contribute to that. There's things such as just health literacy, their educational level. Do they not know that, they should be having a primary care provider? What those issues may be, or maybe they don't have a, good understanding of who they should be seeing for the care that they need. There's the social determinants of health that, you're constantly looking at housing stability, food insecurity, things like that. There's so many different factors that can play into why somebody may go to the ED versus using their PCP. And I think that the best way to kind of explain it is we have a member who I can show as an example, but a mother, she has multiple children, one with asthma, severe asthma, to the point where they were utilizing the ED pretty regularly, probably about once a week, and weren't being managed by their primary care doctor, probably wasn't seen there for almost a year and a half. So they were using it because they were running out of their controllers, their rescue inhalers, so they're using the ED, they're prescribing, and that just seemed to be the easiest avenue for mom to get there, because when you have, as you all know, multiple children, you take one to the doctor, you've got to have somebody watching the other children. So as a single mother with, 3 or 4 children, it's not always feasible. So really, we got involved with this case, and we had a certified asthma educator go out and meet with her and really just talk about what's going on. What are the things that stop you from getting to the ED? Transportation is one of them, childcare. Really looking at what we could do. And then in that visit, that home visit with the member and their mother, realizing all the triggers in the home that were taking place. And mom had no knowledge of it, and nobody ever really talked to her about triggers in the home. And so when the child would lay down in bed, they'd have all their teddy bears and whatnot. It contain allergens, so they would trigger this. So they would be in and out of the ED, they'd get better, go back in. So the nurse went out, talked to mom, really, dove in, we use the term peeling the onion, really looking at every layer, just to see, what's going on, what can we do differently to kind of prevent this from happening, and really get the child linked to the most appropriate care. So we ended up looking at, getting the child linked to care, getting some in-home support, then also looking at housing as a huge factor. The housing apartment she was renting also was full of cockroaches, another trigger. So looking at different housing options. And ultimately, over a course of probably about a year, we worked with this member and her children, and we were able to place her into a different housing setting, reduce some of those triggers, really teach her about, what things to avoid, link her to that care, and, find the transportation and show her, exactly how to actually set those up going forward. So we're there to support people and get them to where they need to be, but also helping them understand how to do it themselves. So it might be a little bit more hand-holding in the beginning, but then kind of back off. And these are the 5 different, domains that tend to make people, I've discussed some of them throughout, but if you can't see them in the smaller print, are we sending this out electronically?
They have.
Oh, perfect.
You can't read the,
You can't read it.
not the box.
Okay. So we could probably maybe send this out electronically so you can see this. But it talks about all the different areas of social determinants of health that really impact somebody going to the ED. Like the affordable housing, health literacy, touch on a little bit of each of that story. So the impact really of inappropriate or not using an ER for what it is $38 billion in wasteful spending each year. Spent in emergency room usage that could have been served by their primary care doctor or specialist. So really, looking at affordable ER's use and diminish the quality of the ER, creates crowding, wait times, and again, your patients don't need to be there for that. So really taking away the time that those providers in the ER setting should be dealing and addressing the issues of somebody who's got a true emergency. And again, simply emergency rooms are not primary care doctor settings, which we all know. Very important that people need to know the difference, and that there are other options. We'll get into that a little further on in the slide deck, but there are other options to the ER. So. factors that drive avoidable ER usage. So lack of understanding about what's emergency versus a non-emergency situation. Something as simple as, you know, sore throat. We're going to go on to that next page, so I don't want to go too much into the weeds here. The reactive versus proactive pattern. So you've got somebody who's going into the ED because, you know, at the last minute they decide, well, you know, sore throat is going on too long, I'm going to go to the ED, versus maybe catching a little bit earlier on and seeing their PCP. So waiting, you know, kind of waiting to the last minute. Social disconnection or isolation. So really, location. You know, it might be easier to get to the emergency room versus to the PCP or even urgent care. You know, so they may be, they may not have the means to get to that point, or, you know, in the case with the child care scenario, she might not have the child care until the evening, so then she's taking the child to the ER versus going during the daytime. So there's so many different factors. Many members who are, you know, maybe homeless, or they have food insecurity, they're hungry, they're cold, they go to the ER for a warm place, bed overnight, particularly in the wintertime. Cultural differences, lack of transportation, that was one of them. ER is the closest option, which tends to happen often. Cultural differences in experience or expectations with the healthcare setting. So some of these members that we serve, it may just be their cultural experience to, you know, seek their care in the ER versus having a primary care doctor, or they've had a negative experience at a PCP office, and there's so many different factors that play into it. And then again, generation, pattern of seeking care. So tends to be poverty can go in generational poverty. You know, that's all people have known is I go to get my care at the ER, not to the PCP. So really trying to break that pattern and showing people that there is a difference between the emergency room and the PCP, and the value of seeing your PCP. You know, so somebody who should know your care and the continuity of care is important. So, you know, looking at that. Avoidable ER usage, perception that's only option available in some scenarios. There's some challenges associated with discharge planning and coordination for previous inpatient or ER visits, which may result in you going back in. Health literacy barriers to follow treatment instructions. So do they really understand when they're being discharged home what they're actually being told to do, or what they should be actually following up with? So really making sure that when somebody's leaving the hospital or even just leaving their PCP, that they really fully understand what the doctor or the nurse actually just talked to them about. You know, it happens quite often where people come out of the hospital and they were discharged home with different medications, and, you know, they're following the directions, but they've also got this stack of medications at home still, and they start resuming those. So it sometimes can be very confusing. And then unaddressed mental health and substance abuse issues. One of the largest drivers for ER usage. You know, with just the general area, we have a shortage of providers for this. So I think that drives some of it to the ER, but trying to catch some of those issues earlier on and linking them to providers help with this. And then paying your medications or using the ER as a pharmacy when you're out of meds. One of the biggest things I can't figure out, but the MAS transportation for Medicaid, bring you to the doctor's appointment, but we won't bring you to pick up your medications. It doesn't always make sense, but people, you know, need their medications, and some people know they need them, so they go to the ER and they get that script filled. And the other flip side of it is they're prescribed it in the ER, and then they're not following up with the PCP to get those continued prescriptions, so they're going back in. So what do you guys see as other factors that drive avoidable ER use?
You get a ride home from the ER.
Sure.
Transportation is a huge, I work with the mental health population. Availability, ER is available on their schedule when they need it. They get a ride home from the ER. If they try to get into the primary, they're going to be told it's an emergency, go to the ER. Well, in their world, especially with the mental health population, it is an emergency. It's the now.
Right.
And so that's a huge factor for us.
Yeah. Transportation even on the front end to get to the ER. You know,
we talk a lot about getting mental health services embedded in primary care. In fact, I just went to a conference on that, getting mental health services embedded like in OB offices or primary care offices. But the real conversation for us is getting primary care services, healthcare services embedded in the mental health clinic environment. Mm-hmm. And that would save, I know for our clinic, it would be, we have over 500 clients. It would be huge for us to be able to have like an ER, like a Albany med resident or something in our clinic
Very true.
embedded there one day a week, I think would be, make a significant difference.
We do focus on putting BH into the PCP offices, but why not bring the PCP to BH? If you've got the 500 members going there, patients, it would make sense. Great concept.
Any other factors? Yes.
I don't think I heard you say it, just access to PCPs in general right now.
Right.
It's hard to get an appointment.
Yeah, what happens is the client doesn't show up to the primary care doctor, and they do it like 2 or 3 times in a row because organizational skills, whatever their issues are, cognitive problems, then they can't go back to the management primary care doctor's office, and their options are so limited, especially when they're on Medicaid.
Exactly.
Another big problem.
Practices are becoming much more stricter these days with new patient appointments, so sometimes if you miss one, you're automatically discharged from the practice, so they are becoming much more strict. And for our roles, especially mine, we can only do so much. I do the appointment card, I will give you a reminder phone call, I can only do so much, but we do have community health workers that are able to physically take members to their appointments, which is great, but that's if you have that resource to do so, right? Okay.
I think it's easy for, like the Medicaid population and the mental health, but, Medicare and older patients, that's a factor at times too, and families that can't care for those patients that, okay, we're gonna go to the ER, and I can't get in with the primary care provider, and then it becomes a transportation issue, and I can't wait for my PCP, but, older clients, Medicare population,
Very true.
they sometimes utilize to the ED, but definitely your point about mental health and having somebody embedded, like where I work, we have 12 PCPs, and there's a social worker, she could possibly do counseling, but having somebody there 1 or 2 days a week would be kind of nice too. It's a whole gamut.
I was gonna say too, then I won't talk anymore, but for some folks that tend to isolate or don't have family or friends, it's company for them.
Yeah.
Very true.
They show up, they get, there's nurses, there's mice, they get Jell-O.
They're recognized.
Right, exactly, they're recognized. So I think that there's a social component to that as well, depending on who the individual is.
Most definitely. Especially, if you're sitting home alone every day, and, your only interaction is going to the ED and talking to the ED staff because you've got something going on, that may actually occur, and you can understand why. But how do we actually get members to, maybe look at different avenues to have that interaction with other people? And again, it comes down to a lot of it's behavioral health, mental health issues, so making sure that, they're being cared for appropriately. But no, absolutely, it's social piece and isolation, and particularly with Medicaid and our older members as well, our Medicare members happens often.
I've had a lot of Medicaid people say, well, I can't use the same day visits as primary because MAS won't let me. And I try to tell them it's really not true. It's explain it. And,
correct.
But as you all know, calling MAS, some of the staff at MAS can't take each other's impulsive things that they might say. Or I think you know what I'm getting at.
And MAS is very challenging. We have a specific section as presentations for that, but when I do my health literacy classes, I always encourage people to don't be afraid to really hang up the phone or ask to speak with someone else. And it's very challenging.
Online?
You can do it online if they have previously scheduled transportation in the past.
We use
You
a
can do it
lot.
online, yeah.
Yep.
And
we had, her name is Shelley, came in from MAS, and
Shelley
and she, so if we have a problem on the phone, then we just go to Shelley, and she's been great.
I was just gonna say, just to ask this, but I know you're gonna talk about MAS. Shelley Crow is, she works for MAS, and she's more or less like a regional director for this area. I highly recommend, and I can get you her contact information, if you're struggling with the MAS system, to have her come do an in-service with you. I think it's very informative, and it'll provide a lot of insight. It sounds like Allison's having that now. So, and I know when we talk about it, we'll talk more about circulation maybe a little bit too, and how they tie in, and I think to have an understanding of both of those, as far as what we rolled out to the community to help address some of these social determinants of health, she's a great contact.
Wonderful.
Thank you.
Yeah.
The other point that I wanted to make for this is the crisis, the crisis-driven population and immediate need. So when they go to the ER, they're getting that immediate need. Where when I'm trying to educate them on going to the PCP, then it's blood work, it's follow-up appointment after, and that doesn't build in with them, It's like, I just want the need that, I got a headache now, I wanna know what it's from and get it taken care of. I don't wanna have to go through all those steps and follow up, and they just look at, there's a perception of the primary care as visit after visit after visit.
And it's definitely changing that perception of what it is. And what I try to do sometimes as well is explain, well, you're gonna be in the ER waiting for a really long time. And what if your headache does come back? Do you wanna go back again and then wait for all those hours, as opposed to having a doctor that already knows what's going on with your headache, that knows your history, then can address it a lot more better for you. And a lot of the time I found that it's really talking through situations like that with individuals, just really sitting down and having them explain it out loud really helps with that decision making too, which we'll talk more about.
She brought up a really, I don't know her name down there, but she brought up a really good, what's her name? Kendall. You brought up a really good point about what you thought was the reason why people go to the ER. And I'm sure this has been done, but I've never seen any data on it. But I know we are able to formulate why we think clients go to the ER. We have all our reasons, and a lot of reasons, so we can conceptualize it. But is there research out there as to what clients are saying, why they're going to the ER and not going to the primary? Have we actually done surveys with clients and try to get their reasons and then reconcile those with ours and then come up with a plan?
I think this gentleman back here can help you.
Yeah, actually, I guess my timing was good. Hi, I'm Kevin Jobin-Davis, the Executive Director of the Healthy Capital District Initiative, and we did a survey of over 1,000 consumers in the capital region at each of the hospitals in the region, and so we have that all that research on our website, but if I can summarize and remember back then, the biggest driver is pain. The biggest drivers are pain and convenience. So the different types of pain. So if you look at the health conditions, like 5 of the top 10 health conditions were pain related. Lower back pain of different types. And then I don't have the right categories, but 5 of them were pain. Oral health pain was big. And then there were convenience issues. There was a lot of cold type symptoms. But then if you ask for consumer opinions about, what were the reasons, what not health conditions, but, why did I go? There were a lot of things about primary care access that they were told to go to the ED. It was late in the day. The primary care doctor said, I can't see you today. If you think it's urgent, you have to go. There was more about that. I'm not going to pull up. I wanted to make a point about also time of day was very interesting. People go kind of late in the morning to lunch and after work, so there was kind of how it fits in your workday, so that fits social determinants of health and transportation type issues, or they tried to get in the primary care office and couldn't get in, and so then they end up going to the ED, or they can't go during work, so they go after work when primary care isn't open. Those are some of the bigger things, but I can get you right to those reports if you're interested.
We as a PPS did too, some listening sessions as well. And one of the main concerns that came back as far as why individuals were using the ED from individuals who were in recovery was that they felt when they went to their PCP that there was a stigma attached to them because of, that almost as if the doctor thought that they were seeking medications, or on the other hand, they would be prescribed medications that they felt might essentially lead back to them having a slip. And so again, it was more back to that cultural competency and cultural health literacy being educating the primary care physician. So that was one of the things that came back as well in some of our listening sessions.
People also like the one-stop shopping. It's like the healthcare mall. You don't have to go to your primary care and then go over here for a test and over there for a specialist. You go to one place, get all your needs met. And there was some opinion about people thinking that that was the highest quality care.
Yeah.
You know, they have the most expertise there, so why would I go someplace that they don't have all the equipment and don't have all the experts? I'll go right to them. If there's no downside to it, which is particularly true in a Medicaid population where there's no cost sharing, and you can say primary care and urgent care are much less accessible in an urban environment. You know, the urgent cares are in the suburbs around the cities, and primary care is also a little more outside the cities for those certain factors as well.
That the play is almost like on the words, right? Like emergency equals important equals takes me seriously almost, right? So, yeah.
I'm just curious, I have two questions. One is, did you happen to know how many people actually had Medicaid prior to going to the ER? Because I know, I come back when I was working for DSS, and many people weren't eligible for certain, services because they weren't quite meeting the need or whatever the case may be. But a lot of enrollment occurs at the hospital, either through an admission or through the ER visit, because they're going there. Local providers won't take you if you don't have insurance, or they expect an upfront payment. You go to urgent care, you need to pay upfront. It's $200 a visit. So, there could be people that are, they're not quite where they need to be or can't afford to pay to go to the hospital, or to the primary care, So what they're doing is they're going to the ER, and it's actually forcing enrollment into Medicaid at that time, which backdates. So that's why I was curious how many people, if you knew how many people had Medicaid prior to entering the ER versus those that were enrolled the day of entry at the ER, because there is some correlation there as well, that people are going there because they can't deny access at the ER.
Yeah, so I think it's certainly cost is an issue, and people know that they can get care in the ER, and that was part of the whole churning issue, on Medicaid, off Medicaid,
right.
And so you can always get care if you go to the ER because they're not going to turn you away. But we didn't get quite at the issue the way that you're talking about it, but we did look at utilization patterns by insurance type, and there was really no difference. That you think of it as a low income, perhaps, use pattern, but it's and I don't know that we broke it up urban, suburban, rural, but if you look at it by insurance types, there was not much variation, and actually, if you look at it by numbers of people, then people who are commercially insured were the biggest users for non-emergent care.
Wow.
In sheer volume, yes, percentages, it was very comparable.
Okay. That's good to know. And the other question that I had was, now we, at the mental health facility, we've had clinicians in primary care offices for a decade or more. And part of the concern that I have is that, when we have a clinician in the primary care office, they can only see the people from that primary care office. So they're limited, whereas if we had a primary care clinician in our office, they would see all of our patients. And I know one thing that we've run into is that, in Greene County, it's either the hospital, CMH, owns most of the primary care offices, and then there's a few private. Well, most of those privates have, gone under the auspices of other hospital practices. So there's no driving force for them to come into our clinic. And I'm wondering if there's any push from, I guess I'm going to go to the PPS and say, is there any talks with hospital systems or with provider networks stating, the need or urgency to have somebody really be present in a mental health facility versus the alternative? Yes, because we're not seeing a huge benefit. We have people in the medical office. Now it's gone down, but at one time we had 2 or 3 people that went to like 5 or 6 offices. Now we're down to 2 or 3 offices, and they go 1 day a week. And some of them are only half a days. Like there's not enough patients for them to see there.
One of our initial, and don't quote me on this 100% because I don't work on the behavioral health projects, but was to centralize, just like what you're saying, the behavioral health in the PCP, and it sounds like what you're talking about is the flip. So they're gathering information and data on that. Dr. Majanoff, who is our medical team director, they have the clinical quality affairs. He would really be the best person to talk to about that, because with DISRIF, as we're trying these different projects, a lot of this stuff came to us, these milestones were prescribed. we have to report on these things. So to say it's not working, and that type of feedback is the type of feedback that we would need to say, here's why, maybe this is what we need to consider. And I can't imagine that the behavioral health team and Dr. Mont haven't already been having that conversation. But
Yeah, I'm just curious.
we need to move forward with the training, but we can talk about that, and I'll get you in contact with who would be the best person to get you that information from the PMO.
Okay.
Thank you.
So some of the commonly seen conditions that are in the ED that could be seen elsewhere: UTIs, dental pain, upper respiratory conditions, the common sore throat, back pain, asthma, all common things that could be seen in the ED, but could be actually dealt with at their PCP. So the question becomes, could these be avoided ER visits? And oftentimes they can be. It's making sure people understand what the resources are and they know when to call. To your point, PCP same-day visits aren't always available, but knowing that knowing your symptoms and knowing what you could use over the counter versus before you even go to that point of going to the PCP, or calling a few days ahead if you're just starting to get sick and and make an appointment for a few days down the road and get that appointment scheduled in case you're not feeling better, or and canceling if they don't need to be seen. Just trying any strategy possible to get members linked to that PCP. And to Aretha's point, going to the ED, you're going to wait hours and hours potentially for something minor like this. To them, it is something that's bothering them at that point in time, so they want to have it resolved. But really, you could be sitting there for hours, and then again, if you're not doing the follow-up afterwards, you can be right back into the ED. So there are other things that we could do to avoid members from going into the setting for this type of care. I think everybody's trying. I think trying different strategies, and it's certainly something that we need to continue to work on, but definitely these things here, and it just really comes down to health literacy too, making sure people know you can go elsewhere. To your point, urgent care settings, they're not always readily available, and the ER is the closest place. So it's definitely a difficult thing to overcome and a challenge that we need to look at and do things a little differently.
I'd urge you to keep promoting nurse lines. I love nurse lines because when people don't feel good, they want to feel better. They want to feel better now. They take meds, they do whatever they can, they go to sleep. All these are ways to avoid pain. No one wants to be in pain. And the great thing about nurse line is that it's basically a medical provider in your home, when you want it. And I think you have a bigger opportunity there because it's hard to convince somebody to do the right thing. There's pick your activity, any health thing, you could do it better, right? And it's not, everyone doesn't agree on what better is, but people get instant gratification, they get, and they, in general, they want services at their pace, at their, when they want it, so. Anyways, I
agree with you. I mean, doing a symptom check in, for a nurse line, having that symptom check and kind of steering the person that you're talking with in the right direction, really going through everything and to this weight, what are your options? And then, another selling point for primary care providers is they all have 24/7 support lines. So that could be another way to kind of entice members to link up with a primary care, is that you will have that 24/7 support. If you have got a concern in the middle of the night, call, you're going to be linked to the on-call doctor, or potentially the nurse, and have that symptom check. So
that's just one of the strategies. Other strategies that we can discuss today to talk about reactive decision making is really addressing the tyranny of the moment with that individual. So firstly, by reactive, we're talking about, as we've been talking about all morning, is that those quick impulse decisions that may not necessarily be the best ones, but to that individual in that particular moment, it is their best decision, and to them it may seem as if it's the only decision, right? And a lot of the time it's because individuals are really in that crisis mode or that tyranny of the moment. So when someone is constantly at a really high level dealing with housing or a job or violence at home, they're always operating at a really high level. So when something happens that may warrant a trip to the primary care doctor, to them it's really a trip to the ED, even though it's something that may warrant a trip to the urgent care or their PCP. So really, how do we get them from out of that crisis mode or from being underneath the tyranny of the moment? And really it's about addressing the social determinants of health. So figuring out what it is that is really significantly impacting them at that moment in time. So there may be multiple things going on, right? But it's mostly important to firstly not overwhelm them with trying to handle so much at once. And then secondly, it's to deal with what is most important to them at that point in time. So if you're concerned with trying to get someone established at a primary care doctor, but they're about to be evicted, there's no way that they're going to be worried about, going to the PCP anytime soon. They really want to go to the ED, get that out of the way first, and then deal with their housing situation. So figure out first what it is that is most significant to them at that point in time, and then address it, and then take it one step at a time. And then addressing these different social determinants really will allow the individual to have a clearer mindset in order to make the right decisions or the best decisions for them. So, of course, when they are out of that crisis mode, or when that crisis mode seems a little bit more bearable for them to handle, then we can talk about being established at the medical home, at the primary pharmacy, or the dental home. When I do sometimes talk with individuals about being established at a primary care doctor or preventative care in general, some of the times I get the reactions of, well, I'm sick, I need to go to the doctor, or I know my body, or I feel fine, what do I need a primary care doctor for, right? And this is where reactive decision-making comes to play. So as opposed to simply just waiting till you're sick or till that side pain gets worse, it's really about not reacting to something getting worse, to something significantly happening to you. But I try to tell people it's really about making sure that you're fine overall, getting that confirmation that, yeah, you may feel fine, but just get that confirmation that you really are fine. And then I really explain and I hammer on that going to the doctor is not just for sick people, that you don't have to be sick to have a primary care doctor or to have a dentist. You don't have to have tooth pain to have a dentist. It's really about maintaining that state of health that you feel that you are in currently. So selling the value of a primary care doctor. So once they're already established, it's really important that they know that visiting the PCP is not just simply for physicals alone, that they're going to be that one person that links you up to resources in the community if they do have a comorbidity or a chronic condition that they have to manage with other specialists, that their primary care doctor is going to be that one person that they really have to touch base with should they have any of those chronic conditions or comorbidities. They're going to be the ones that they call for prescription questions or medication questions. There's been many times where I have had members that were due for colonoscopies or mammograms, and I would call their primary care doctor office that they were established at, and their doctor would refuse to write that script for it because it had been so long since they had even touched base with their PCP. So even if that individual does have a primary care doctor, it's still making sure that they are having those regular checkups, those physicals done with them as well. And then understanding that the client should understand that they should really have a relationship with that primary care doctor. So by relationship, I mean that it's so important that they do know that it should be a two-way conversation back and forth, that when it comes to avoidable ED usage and medical care in general, it's really about empowering that client to understand that their health is in their hands as well, not just that person in that room with them, that it's a two-way conversation back and forth, that they are empowered to ask questions, they are empowered to ask why, and that it's a relationship. So if they feel like that relationship is not working, as in if they feel intimidated or they can't ask questions, then that's really a sign for them to really move on to the next one. And they really should not be afraid to do so. A lot of people feel that when they get that ID card, that doctor that's on that ID card is the doctor that they have to stick with forever down the road, and that's never the case. So it's important to know that they do have options. So if the individual does not have a primary care doctor, exploring the reasons why. So is it simply because they don't have one, they don't like them? I get that a lot. So they may have a primary care doctor already, but they just haven't been in a long time because they simply don't like going, and they feel like they're supposed to be going to that one in particular. And because they don't like them, they may go to the ED usage to get treatment elsewhere. Is it too far? So again, exploring, is it a transportation issue? Is it too far? Are they open to maybe having a primary care doctor that is closer to them by chance? And then are they too busy to find one? So knowing what your resources are, the community health workers or advocates at your agency that can help them or assist them with finding a primary care doctor. And then is it because they just don't like going to the doctor? So maybe having an advocate with them to attend that appointment with them, or again, explain the significance of having a PCP in the first place. Because, they may not like going to the doctor, but honestly, does everyone like staying in a waiting room for 4 to 6 hours at a time, sitting there? I don't think so. So coaching helping to build a successful provider and patient relationship. So once they have already been established at a primary care doctor or a dental office, so really helping them to have a successful visit and make it to that first appointment or that next appointment. So really acknowledging any fear, anxiety, or bad experiences, just knowing that, really it does happen that people do have really bad experiences with a doctor, especially dentists as well too. So addressing that fear and anxiety and maybe offering, if it's appropriate or if you have that resource, to accompany that appointment with them. 2 weeks ago, I attended a women's health class, and at the end of the class, there was a woman that was really overdue for her mammogram, but she was absolutely terrified of going. And so I accompanied her to her appointment. She successfully made it to that appointment. So really having those resources available, if you do have them available, to accompany your clients or patients to those appointments if need be. And then discuss what they can expect from the appointment. So sometimes it's really the unknown that really, really scares people. So helping them to understand what to expect from the appointment, maybe even calling the office ahead of time, especially. This is really helpful for parents for children who are due for their dental visits. Parents tend to be really apprehensive about that, particularly because it's a child and maybe their first visit. So I always encourage them to call the dentist and to just talk to the dentist about what can be done, what's going to be done in advance so that the parent can, relax, and because the child sees what they see. So if they're fearful, then the child's going to be fearful. So really understanding what they can expect from the appointment is super helpful. And then helping them to prepare any questions. So I always stress that going to any type of appointment is so important to have questions to ask, whether or not you have a chronic condition or an issue that they may be dealing with. So in your packets, you do have a tool called the Ask Me 3, which reviews 3 really basic questions that individuals should be asking the doctor for any appointment. The questions themselves can be tailored, but overall they are, what is my main problem, what do I need to do, and why is it important for me to do it? I always stress that the last question of the why is really one of the most important ones, because we can't just simply receive information. We have to understand the information. We have to know why we're being told to do certain things or being told to take certain things. On the back of the sheet, the individual is able to write down the answers to those questions, but again, they can certainly modify them. So the questions can be, do I have any questions about my prescription, or do I have any questions about this regimen that my doctor has put me on? Regardless of what they are, it's so important that they are prepared for their visit. They may have the questions in their mind, but then when they get there, they may forget. They may have white coat syndrome and it's suddenly blank when they get in that office. So this is really a great tool that helps them to be prepared for their visits. In addition, your packets also do include a health tracker. So this booklet right here, which would allow them to write down all of their doctor's information right on the front page. Inside, they can keep track of their appointments, their medications, the last time that they had a mammogram, a pap smear, a flu shot, a colorectal cancer screening. So these are just examples of different tools that you can utilize to keep your clients and patients on board and on task. And then in addition to that, we also have in your packets these mini medication trackers. So I always encourage individuals to keep these on hand in their wallets, pockets, purses, just because, most of us would agree that medications have really long names. A lot of people may not even know what the dosage is for these medications. So it allows them to have that with them, particularly if they are going to a new primary care doctor, they're going to ask them to bring a list of medications with them, right? So this will allow them to do so. And then the last resource example that we have is these appointment cards. So individuals can visually see what their appointments are. There's even a section for them to write down 3 questions that they can possibly bring to their appointment as well. So these are just examples of resources that individuals can have with them on hand, or that you can provide to them to really keep them on track, to empower them and help them feel a little bit more comfortable with visiting their doctor. Any questions so far on those tools or resources?
Okay, 2 things. One is, I appreciate the logic, but we're still trying to convince people to behave in a different way than they are. So, and in that, me saying it is not the same as having good marketing materials, if you will, things that are really short and just are clearly beneficial. You know, people do what's good for them. So if you folks have or create things that let consumers know this is how you benefit from going to primary care, because it's all kind of long-term investment. It's like that's the right thing, or it'll be better over time. It's like buying insurance. You know, it's yes, it makes sense, but when you're in, you know, when you have more crisis, less resources, long-term investments are not how you're operating. You're operating in short-term benefits, and so I encourage you. You know, we would use anything that you created that was short and clear about this is how you're going to benefit from going to a primary care. The second thing I'd just offer up is I appreciate the health tracker. I have a senior that, you know, my father I'm taking care of. He goes to the doctor all the time, and he cannot remember what the results were of that visit, and the doctors are still improving the way they communicate with each other. And I don't think he's alone in that effort. And so I was actually eagerly looking for that in here, but it's not quite the focus. But if you had anything about appointments and results of appointments and the meds that went with it, that would be another way for someone to kind of track their healthcare experience. So, you know, because you went, you learned something. How long do you remember that? Is, I think, a challenge for everyone. You don't have to be, 80.
That's a great point.
Right. You know, to have trouble with that.
And just to piggyback off that, I mean, a lot of primary care and specialty offices should be providing a clinical summary, a visit summary, which includes your medications that were prescribed at that visit, any lab results. I think that is, that's a meaningful use measure, so I don't know that there's many systems that aren't doing that.
Well, I would love that, but I would say that less than half the time he gets something like that. So of course I try to go to his healthcare, and I'm using him as an example because I'm familiar with him, but with his experience. But less than half the time he gets it, and it's not always in a format that's super consumer friendly. Some people are very good at putting in details that you need, but it's, you know, he's down to basics. You know, what am I supposed to do? You know, when he wakes up in the morning and doesn't feel well, what should he be doing? What's his med? Which med does what thing? Or, you know, what's his action steps? And, you know, again, maybe that's too specific for his situation, but I'm saying somebody who is trying to act on their doctor's instructions, we know medication adherence is poor, right? And some of that is clearly about access to the meds, and some of it is about knowledge and retention about how to use it and how to benefit. Asthma ED visits are a huge problem. People still cannot get straight maintenance from emergency meds for asthma.
Right.
And until there's a clearer way of doing that, they're going to keep going to the ED for that.
I would agree. So, I mean, I go to the PCP, I get a printout of that visit, right? It's in a format, I can understand it because I'm a nurse, but if you break it down, if I gave it to my wife, per se, would she understand all of it fully and what all of it meant? Probably not. So I do agree, like, you know, we're preparing for somebody to go to the appointment, but on the flip side, you've seen the PCP, you've had the appointment, breaking it down to that level of, you know, this is why you take this medication and this is, you know, the result. You know, breaking it down to that level, for some people, is definitely necessary. And if you're providing care for particularly elderly people, and again, you know, if you're not able to attend every visit, but they're capable of attending it, but you need something back, it needs to be user-friendly, you know, and appropriate for the people you're serving. So, I mean, every person's going to be a little bit different, but the one printout may work for some, but I agree, there's definitely different tools that, you know, we should look at potentially to, you know, relay that information back and forth, and then have it stored in a safe place so that you know exactly what happened. And bring it to you if you go see a specialist. I mean, make that connection with your PCP specialist, and all that information in one spot is actually not a bad idea. It's a great thing.
I was just curious, I mean, these tools seem very helpful, and I think people coming into behavioral health are not necessarily health literate at all. I mean, they don't even understand the repercussions to the meds they're prescribed in our clinic and how they correlate with their behavior, and then, you know, the other external factors that are their health conditions that are also impacting their behavioral health issues. So I mean, one thing, you know, it's easy for some of us at an administrative level to understand the whole correlation and how it all ties in. Even at the clinical level, there's, you know, behavioral health specialists that still don't understand the tie-in to their whole body health versus their behavioral health. And I'm just wondering if there's any opportunity for CDPHP to come in and, you know, do a presentation. We can, you know, plan a group night and we invite people from the clinic, the patients and staff, and say, okay, you know, we're going to do an in-service today from CDPHP, and, you know, just to kind of, I mean, from your standpoint, to be able to project to the clients and to your users, like, hey, this is why you should be doing these things. Here's some great tools, you know, like, I mean, we can't come up with this material ourselves. I mean, it's not something that we would be able to afford. So it would be nice to know if you would be able to, you know, be willing to at least do an in-service with our staff and our clients, so.
Definitely looking to do that.
Do a YouTube. Like a little YouTube video that you can show periodically at different environments, that, you know, waiting rooms, clinics.
Yeah, and we're working on something like that as well. It's just, I think it's more, you know, I mean, they're always thrown with stuff. I mean, they get the care managers are calling them, and I mean, I can actually appreciate, I mean, my grandmother has CDPHP, and she's like, CDPHP's calling again, you know, and she, you know, she's a diabetic, she's got back pain, she's like the high, you know, but she has no, like, she doesn't even understand. She thinks you're, like, sales marketers calling. I'm like, they're calling to help you. Like, they have a care management team. They're calling to help you. And she's like, I already know who my primary care is, click. And I'm like, okay. So, I mean, I really think that, like, it's, you know, you're out there, and I think you're doing a great job of trying to do the outreach, but I really think a face-to-face and realizing that, like, you're not some, you know, telemarketer from the Middle East calling to ask them what they're doing. I mean, because that's really what they see. I mean, I can tell you firsthand that's what, and she's a, you know, a pretty intelligent person, but she's like, no, I already have it. It's all set. Goodbye. You know, like, I mean, she doesn't even answer the question. She won't even get that far. She'll pick it up and hang up the phone on you. So, like, I just think that it's, you know, we throw so much stuff and information out there, but I think it's what people actually absorb and what they take in is really important. So the face-to-face contact and materials, like you suggested, would be probably helpful for us to pass out, and, you know.
I think it is it goes back to the buy-in for the PCP and making the phone calls. Like I said, our case management is new in the outpatient world. And I don't know about you, Brenda, but when I call patients to follow up if they've been in the ER or have been inpatient hospital discharges, I get thanks for calling. Whoa, wait a second. I can see everything right here that's going on with you. So there are things available that we can work on and talk about. But it is a buy-in and a communication that's still in the outpatient PCP.
I think it has to come from a trusted source. So the nurse is their trusted source, and she's educated with the material, or the PCP. But there's so many hands involved that they forget who they're talking to, why they're talking to them. I already told this to, you know. So if we can get to the patient's trusted source and educate them and give them the materials, then that's the connection.
We also have a portal system, which is nice. Our patients can type in. They have access to our indirectly the record, that if they want to talk, not on the phone, but if they want to send a message, it'll come right to us. Another way of triage.
Yeah. That's great. And we can definitely touch base afterwards on that service as well, too. Yeah, but to that point, there's been times when I would call members and they're like, is my insurance terminated? Like, why are you calling? I was like, no, it's like, oh, you can actually do that. Well, yes, of course.
There's that stigma attached to insurance companies, right? We're really calling to actually support people, you know, and not actually be the one who's saying no to a prior authorization, or we denied this, or your coverage is termed. We're actually calling because we actually do care. We want to actually assist people. And I think that stigma breaks down that wall. I mean, in the 10 years I've been at CDPHP, we started as a strictly telephonic unit, which when I first started, I was thinking to myself, how does this work? I would spend so much time dialing, not reaching people. It made no sense. But then, you know, 3 years into my time there, we started embedding into PCPs and having those face-to-face interactions with members, way more meaningful, way more impactful. We have nurses now that are embedded at our local facilities, the hospital, so they're meeting patients at the bedside, introducing our case management at the time of discharge. Saying, you know, you expect this phone call, here's what they're calling about, selling to them at the bedside, and we've seen a huge engagement rate, increase, just because they're knowing that we're calling, and we're not calling for any other reason other than to support them. So really, we agree that face-to-face interaction is key.
Did you say you don't have them embedded in the practice anymore?
We do. So we still have nurses that are embedded in practice. One of them is actually at Oldendorf's office, Dr. Oldendorf, so she's there as well as one of our behavioral health case managers. But we're also embedded at the local hospitals because we know that face-to-face interaction, introduction to case management is so meaningful for the back end, and plus you've got a head in the bed, a captive audience. So if they're there, let's go and meet them there, and then talk about not going back there, so that face-to-face thing is key.
Chris, is there a way, like,
Sure.
topic, I need to know, really, is there a way to know which of the CPHP patients that we have that are on a telephonic care management program? Because those patients, I do notice, get a little confused when they get calls from all of us.
So I think there's definitely mechanisms that we could, look at and share with providers who their patients are that we're actually engaged with. We do send out a letter to providers that states that we're working with the member, and if they have anything that they would like us to work on, please contact us. I don't know if that makes it.
That would be nice to know that, because they probably don't put them in the record, so I wouldn't know, so thank you.
Right, so we do, yeah, so anybody who's being case managed, we do send a letter to the provider in hopes that, one, that if they have anything they want us to address, they can certainly give us a call and they have that direct line.
I've seen the ones about landmark. That's different.
Landmark, right, so it's a case management program, which is CDPHP as well for our Medicare population. But yeah, we can certainly explore options for that.
One thing I did notice, and I mean, this might just be because we don't have enough population or covered lives, but like I noticed that Columbia and Greene counties aren't listed in any of your materials and.
So we actually just moved to the North Country, so the transportation sheet that provided for you guys, it's not our updated one. That one has Columbia and Greene.
Oh,
So we just moved to North Country, what, 3?
July 1?
Months ago was July.
Yeah.
We moved into the North Country. So we actually have been doing a lot more outreach up there now, in addition to events and outreach opportunities. We're going to do more.
We're worked out.
You're not.
Oh,
Yeah.
You
I'm
guys.
directionally challenged, so it's like when you said green, I'm like,
a
oh,
lot of
North
information on our
Dakota?
website
No,
about it.
What's that?
Each CDI has Columbia and Green, transportation, and a bunch of different resources.
I just noticed we're a very deprived area and we don't have specialty offices. Greene County doesn't have their own hospital. So, I mean, there's a lot more challenges that we face. We have a population base of 40,000 people, and we have one primary care clinic group that's owned by CMH, and then there's, like I said, just a couple independents. So, I mean, it's really challenging for people in our area to find people to meet their needs. So it'd be interesting to see, like I said, I think there needs to be more face-to-face, because you calling from Albany is not going to help somebody that's in, the mountaintops of Greene County. So.
Can I ask you a question about how many subscribers know that this booklet exists? And how do the Medicaid patients know that this app exists for them?
So a lot of it is face-to-face interaction. So when we're out at community events or teaching community classes, we always hand these out or bring a number of them with us. When Chris's team is working with any members that do have chronic conditions, they're provided to them if they want it as well too. So and then the app the same way too. So it's really about having members to know what resources are available to them, because you don't know what you don't know. So really, whenever we're trying to engage with individuals face-to-face or over the phone, we try to offer these resources to them and make them aware that they are available.
Is this something that we can request as an agency? So, our agency is a navigator program that rolls in Medicaid, CDPHP is their health plan, and then we also do the health coaching with them. So is it something that you can provide us with, to provide them when they do enroll in?
The health tracker? I can check. I don't think so, because I know we don't provide them in large quantities that way, but I can still double check for you. Any other?
Well, not necessarily a question, but just kind of, if I'm a high usage ED user, I go to the emergency room at the end of my visit,
they'll give me a kind of synopsis of this and a bulk of paperwork that'll basically tell me what my prescriptions were for, what I was paying for, what tests, and then they'll even do like a breakdown. And so I'm kind of used to that and to understand that someone who may not be as health literate, I may continue to go back and forth to the ER just to have a better understanding of what's going on with me versus going to my primary care, me filling this out, and not necessarily understanding what they're telling me to interpret it to even put in the health tracker. So I just was thinking of that as we were talking, especially when you have low-income individuals, they go to the ER because they have a better understanding of what treatment they receive. So we all can kind of fill this out. You know, my grandmother can probably fill this out, but some of my clients may not be able to fill this out and then continuously go to the ER just because I know it's gone on to me. Then I can even provide this to my employer and, you know, I can get a doctor's for my PCP, doctor's note, but I have a lengthy understanding of why I was seen, what's going on, what prescriptions I received, and of course to follow up my PCP, but I might just go back to the ER.
And I think that circles back to, you know, the health literacy piece, really understanding the importance of the PCP, you know, ensuring that they understand, you know, going to the PCP and having the confidence to be able to say to the PCP, I don't understand what you're saying to me right now, can you say it differently, or, you know, or if we're accompanying somebody to the visit to help, you know, walk them through the initial visit and then, you know, help them, you know, prepare for subsequent visits and let them do those independently. It's really around that knowledge piece, because the PCP is just as able as any provider to provide that breakdown, and should be providing that breakdown.
I was just gonna say, so I guess tied into a couple things earlier, you were somebody over here said something about having that trusted relationship with somebody or knowing who, again, their credible messenger is. Who am I gonna listen to? Who's credible? Because you're a nurse just because you say it, but I trust my daughter-in-law type of thing. I think it's important to know those things. And even though they might not necessarily be able to fill this out, I'm kind of putting my case manager hat on right now, and I'm thinking to myself, how could I modify this and create my own tools to use with the individuals that I work with? Because it's very important to know the language of the person that you're sitting across from. And when you develop a relationship, I know this might be too much, but I could simplify this somehow, just a couple points. And again, knowing what their agenda is.
We actually have something similar to, like, that you're speaking to. It's called the next step sheet.
Yep.
So when they leave our office, they know exactly what happened that day and what needs to happen next. That list, you know, like, you have to return with pay stub, such and such, or your appointment at Dr. Smith's office is the following day, bring the following with you, you know, like that type of thing, to try to simplify that and based around what we're doing.
Yeah, so I think that's gonna be, you know, something that's an important strategy for organizations to do as well. Because I said, even when I look at the Ask Me 3, it's like, oh, it's just 3 questions. There's a ton of words
Before it.
on that paper. But if you could just, you know, Aretha said something earlier about kind of simplify it and, you know, explain to someone, again, that whole health literacy what this means, and say, you know, ask and kind of promote them, you know, self-managing their own care, because once they leave the doctor's office, it's all on them. So it's important to meet them where they're at.
Exactly. Yeah, and it's one size fits all is not going to work. So to your point, I mean, modifying it, you know, there's a template for you. You know, certainly what works for some people is not going to work for others. So really modifying for what their needs are. So I think we've go through the slide, but really the importance of having a PCP. I think we all know those things, but you know, lack of access to or understanding of medications can lead to avoidable ER usage. So really the PCP office. Being that first point of contact, being that trusted person, that source, you know, of truth, you know, going there, having that relationship, building it. And I do think it's definitely when you're seeing a new primary care doctor, it is challenging in the beginning. You know, it's a brand new doctor, you're their patient, and you know, but you go there consistently, you get your preventative care there, you go there for sick visits, you start to build a relationship not only with the provider, but the office staff, so they know who you are, you know who they are. So I think it's just that piece around making sure people understand that, you know, it is important. You can build that relationship up. They're there to support you. You know, all the resources that they have available to them is key. And, you know, encouraging people to ask questions. You know, I see it happen. My kid's pediatrician will does this really bizarre thing at the end of the visit where the conversation hasn't really ended, but then she'll turn around and walk out of the room. And I'll be like, I still have a couple. I'll be like, excuse me, what can I show for you? And she'll turn around, actually, you know the answers to them. Like, just a couple of questions, I don't actually know all the answers, and when it's my own child, I kind of like shut down a little bit, and I think that happens with people. Sometimes you're having a conversation with a provider, and they tell you, you have this going on, and then that's the end of it. You shut down, you don't hear anything else. So I think having, if you're available to support somebody with a PCP, especially, the initial visit, to, talk to them afterwards and just say, what happened during the visit? What did you like, what didn't you like? PCP is going to, ensure patients are, storing their medication safe and making sure they're getting rid of any old medications. They really should be doing the med rec. They should know all the medications that a patient's prescribed. And really coaching patients to keep track of everything. Using those trackers, granted, some of them aren't ideal for some members we're working with, but certainly, having maybe their own system, what works best for them, to make sure they have all that information available to them.
And one of the ways that I would try to get individuals to understand the significance of medications and how they can affect the body is, I took health literacy training last year, and one of the examples that the facilitator provided was, if I am a doctor and I prescribe you something and I say, I want you to take this twice a day, what do I mean by twice a day?
Yeah, that's a good point.
Right, morning and night, every 12 hours, 2 at the same time, when I wake up, when I go to bed, which could be different for you and different for me.
Yeah.
So all those are right, but then that's where the problem is, right?
Mm-hmm.
So, the example that he gave was it's a prescription that will affect you with horrible nightmares as a side effect, because people will take it in the morning and then before they go to bed. But he said that if you took it in the morning and then before 12 p.m. hits, you're still taking it twice a day, but you're not going to have that side effect. So I try to use that as an example when I'm talking to people about their medications to really understand the importance of asking questions and the importance of having that one pharmacy that you can have that relationship with. And if you were to go to the urgent care or in the ER and, you were to be prescribed something, to still follow up with their primary pharmacy, because what if you were prescribed something that has interaction with what you're already taking? And, so it's really important that, again, they do have that one place that they can go to, that particularly with our homeless population as well, they tend to carry a lot of their old medications around with them, right? So along with the rest of their stuff. So really helping them to understand where they can dispose of their medications and where they can keep them safe as well, too. All right, so the importance of a dental home. Some of this we have already touched on. So we mentioned earlier how it can be really hard to get into primary care doctors, but it can be just as hard, if not harder, to get into primary dentists as well, particularly for new patients, because so many facilities are scheduling several months in advance just for new patient appointments. And there have been so many times where I would receive a phone call for a referral for someone that needs a dentist as soon as possible because they're having tooth pain, but then they don't have a primary dentist, and it's awful just trying to get them into someplace to be seen. And so having them being established at a current location will prevent them from having money issues that would escalate. But the things that would stop that from happening, the barriers that they may have, is not knowing what their benefits are. So particularly with Medicaid in general, it can be very difficult to find a provider that accepts Medicaid. And if they accept Medicaid and they do have a dental problem, and what if they need an oral surgeon? Then you have another barrier, right?
Mm-hmm.
It's twice as difficult to find an oral surgeon that will accept Medicaid. It is possible, but again, it's another barrier, and people just tend to stop there and just give up and deal with that pain. And then they go to the ER to treat that pain, but that pain is only temporary, right? Because it's not actually fixing the problem. So really helping them to understand what their dental benefits are, maybe having an advocate at the insurance plan that knows what the benefits are. Again, part of my role is to help with that or to schedule the appointments for those individuals. And then we touched on this earlier, the fear and anxiety about visiting a dentist that is oftentimes projected onto the kids as well, too. So sometimes I work with parents who have taken their kids to the ED for dental pain. And when I, sit down with them and, we talk about the current situation, they will say, well, I tried to get them into my family dentist, but they said that they didn't see kids. So in that certain situation, as well as many of them, you have family dentists that will see kids, 7 or 8 years old, but if the child is 4 years old or 3 years old, they're not going to see them. So family dentists tend to accept kids at a certain age. Pediatric dentists, however, will see kids that are a lot younger. So we recommend that kids go to the dentist when they get their first tooth or at latest 2 years old. And I explain to the parents really hopefully not to do any dental work, hopefully, but to really make sure that the teeth are growing in well, that there's no rotting, But it's to get them acclimated to that appointment and to that type of environment. And I always recommend that they go to a pediatric dentist. So it's a pediatric dentist that's going to have that facility that is designed for children, that is designed to acclimate them to that type of environment, to remove that fear. And like I mentioned earlier, I always encourage the parents, just call ahead, just to learn more about the visit, learn more about what can be done. Is your laughing gas? Is your sleeping gas as well, too?
Yeah. What's I'm just curious, like, what is a dentist's limitations with regard to accepting Medicaid patients? I mean, is it rates? I mean, what is the reason it's rates? So why doesn't, I guess my curiosity would say, why wouldn't the state step up and, knowing that there's an issue, say, okay, I guess we need to, start being more competitive with commercial rates for dentists? I mean, that just seems like a no-brainer to me. Just knowing that if your costs are that so high for ED visits, what's an extra few $100s a year for dental coverage per patient?
I can't officially confirm it, but this is what was told to me back when we were having this problem, particularly with heart patients. And what was told to me was it was brought up, and the explanation that was given was that providers not accepting heart Medicaid patients are no different than providers that accept commercial and not Medicaid. That is simply a choice, right? That they can't say, no, you can't do this or that. That is just a choice of the provider. Can't really confirm that, but that was what was told to me.
I know my mother works for our family dentist, and he doesn't take it because of race. So, but my assumption is, like, if there's already an issue with backlog with people getting in. Greene County, I think, has one Medicaid provider.
There's
the primary for
maybe pediatric, and then there's one that's quite a distance from us on the other side in Columbia County. We also have, I'm finding a lot of patients who have a preventative dental only, which does not help when they.
So cleaning.
Cleaning. I'm sorry?
But you're not, no, you don't mean with just Medicaid, would you?
Yeah, not CDPHP, but another major MCO in the area. They have a preventative dental.
So it won't cover all surgery?
So this person, who is already, schizophrenic and becomes psychotic and a substance abuser, now has a toothache and their insurance will only cover preventative dental, so.
The Medicaid
Because
benefit,
Medicaid should be standard across the thing. If you're a health plan in Medicaid.
He may be
you have to provide
an essential plan.
EP.
He may be a Medicare, he may have insurance through a Medicare.
I think the dual eligible, that's maybe better.
Yeah, it's dual eligible.
And the pre-authorizations are tough. That's another reason a lot of the providers don't.
So it was just an issue yesterday that happened to come up, and I thought, Jesus help me, this man's gonna go off the deep end. So, but we don't have, I think we have one in the county that takes Medicaid, managed Medicaid,
We have a population of 50% that's on services, so where 20,000 people are gonna go.
We have Whitney Young that doesn't answer the phone.
You have Whitney, I've sent a lot of people.
Anybody ever gotten them to answer the phone, I'd like,
Yeah, we use them frequently, especially now that it's bigger and the newer dental.
So this won't help with what doesn't exist, but HCDI has a lookup tool for providers by plans or by coverage type, or you can look up by specialty. We didn't create our own, but we brought those resources to one place. So that is a way for you to make sure that the network that you think you know, which you probably do, I'm not questioning that, but there might be others in that.
And where do you keep that information?
It's right on our homepage. We have four, we call them 4 pillars. There are 4 pictures and links. One's about access to insurance, all your insurance questions, and who can help with insurance-related issues and enrollment. One is access to care and finding any issues with engagement in care or affording fits in the coverage, but finding providers. The third is social supports, any of those other barriers to care, social determinants of health type issues, and the fourth is self-management tools. So if you need any of
So you go to the homepage and you hit the health and wellness. And then we'll bring you right to those 4 pillars that have,
And
like,
then,
it gives you an example. Do I need primary care? And then there's a link to finding primary care.
So it's hcdiny.org, and that homepage, you'll see it right, it's at the top of the homepage. You'll see those.
that's
4
helpful,
categories.
because I compile the list to give people who don't have primary.
We actually have a dental link with the ones listed for Columbia, Green, Saratoga, Albany, Rensselaer, that accepts even the straight Medicaid.
Okay, that's good to know.
So just so everybody knows, we actually adopted one of your tools. We had other ones, but after CDPHP saw this one, they were like, that's the one we're gonna go with. So
Oh, good.
HCDI, the Healthy Capital, you'll see their logo right up there. If you can't remember everything that Kevin just said, or if you didn't write it around, if you just Google it, Healthy Capital District Initiative, Albany, New York, it will pop right up, and you'll be able to gather that information too. And he's right, there's tons of resources, the nurse lines that I referred to earlier. Actually, as far as ED utilization goes, I think it ties into so many points as far as what their resources are, as far as what we could offer and be working with our staff and our representatives as well as community members. So
There's a informational piece on there that we hand out to the clients of the benefits of having a primary care doctor, and a lot of resources.
And we're a aggregator of information. We're not, we don't exclude anyone. We're not trying to get you to use our stuff.
No.
You know, our job, but we're publicly funded, so it's so that you don't have to go find it everywhere. We're trying to give you one place.
decentralized, yeah, it's nice to have that decentralized.
That's a good segue to
Great.
actually looking at the tool itself.
Right. So we're actually looking at, the tool that was created by HCDI, looking at kind of the green, yellow, red zone, kind of like an asthma action plan almost, for ED usage versus PCP or urgent care. So it really helps to kind of define some of the things that members will go to their PCP for, and urgent care, the ER. It gives them the space to write in their doctor's information, maybe where the closest urgent care is. So if they haven't used an urgent care, pop in the information for the patient you're working with. And then again, the emergency department that is closest to them. On the back, it gives the patient some additional resources to put in their Medicaid ID number, all their information, their primary care specialist if they're seeing, and any other important phone numbers or contacts that they wanted to have. So it's kind of a nice tip that you can help a patient understand, what zone are you calling in and where do you go for the care you need. And that's a little tool that people can understand.
I mean, it could be as simple as someone really just not knowing when they should be going to their primary care doctor, honestly. I mean, when I was a community health worker a while ago, going back to culture, I was working with a member from Turkey, and he said that when he came here, he really thought that you're just supposed to go to the ED for all of your health care. He just generally did not know. And so this just breaks down the certain symptoms that individuals can look out for that will clue them into when they should be going to a certain location versus the other. And then we have touching a little bit more on the social determinants
of health. So really looking at what do we do in this room, right? So to address them, we have to identify them, right? So where are the social determinants of health? Is it a lack of housing? Are they living in a shelter? Is it a stressful living situation? Is there violence and crime around them that's really creating some fear and anxiety to even leave and get the care you need? Food insecurity, health literacy challenges, things of that nature. And then for us, maintaining a list of those resources that we could link a member to, for every area. So unfortunately, you guys have some resource limitations down in Columbia Green, but there are other things that are available. And keeping that information so that you have it handy. One thing that we find is when we're working with our members, if they have an issue and they're bringing it up and you've got something that's going to help resolve that for them, it helps you with that buy-in, helps build that trusted relationship with them. So really having a robust resource guide, essentially, of what's available for the issues that might be occurring. Seek opportunities to expand support service networks of contacts. So really, meetings like this, sharing some of the materials from HCDI, that centralized location where, they're branded for any particular payer, you can use those resources for anybody. So knowing where that information lives. And then one of the biggest things is, you can go ahead and make the appropriate referrals, but you want to make sure that members are actually linked. So we can refer people, but did they actually make that linkage? Did it occur? Because you're thinking that it did, and if it didn't, how do you make that linkage occur at that point in time? And not letting it just sort of, you've given the referral, well, no, there's action that has to take place, then following up with the person. How'd that work out? What did you think? Did it work really well for them? Did it not work really well? Is there a different resource if it didn't work well? And then, developing your knowledge beyond the four walls that we all, reside in every day. There's other programs that exist. You want to make sure that we have that information available, so that, we can share that information. And it's great to get into a room and collaborate with a bunch of different providers just to say, what are you guys experiencing? What issues do you have? What information do you have to share that, can be used for others? So, making sure you have that.
Team effort.
It is.
So, just going back, this is actually our full list of transportation providers for the counties, the majority of counties, that we covered. So, we touched on this earlier, but I really want to touch base with Shelley Crow, Kendall, because it's just such a pain point for me, as I'm sure for all of you and all of the clients and community that we serve. But really with MAS services, a lot of the time I found that it does depend on who the individual gets on the phone, if they're going to get a bus pass or a cab. So there's a lot of inconsistencies involved. But generally speaking, they will give a cab 3 days before an appointment, bus passes 5 days before an appointment. If it's an urgent care visit, they will, or should, I should say, do same-day transportation to that urgent care facility. And so a lot of the time, they may run into challenges with that. Say that they do have Medicaid and they are in need of an oral surgeon. Likely, that oral surgeon is going to be in a different county, and that is a whole other process itself. So I had one member that was going to an oral surgeon. She's in Albany. Her oral surgeon is in Amsterdam, 2 of them. I had to have an out-of-county form that needed to be filled out by her primary dentist and then sent over to MAS. This was in August, and it's now October, and their forms were just approved 2 weeks ago. So and I had to reschedule their appointments because it just wasn't in the system. And had they not received those forms, the CAP would not have been able to pick them up and take them all the way to Amsterdam. So that's one of the things I will definitely be talking to Shelley about, to see if there's just a different way or a different process that we can do this, but it took that long. So if you are working with anyone in Schenectady, I do know that the Bethesda House, they do have this grant-funded program now that will take individuals not only to and from their medical appointments, but for groceries as well as prescriptions as well. So that is the Bethesda House in Schenectady. I'm not sure of any other locations that are doing that, but I heard about that program earlier this year. So.
And you said there is the website. There's a website that they can.
Yeah.
Is that on here?
No, it's not on there.
Okay.
So you would just go to the Medical Answering Services website if you're looking to schedule transportation online. But again, that individual has to have scheduled transportation in the past. This is very helpful for individuals that do have reoccurring appointments, such as mental health appointments, so they can actually put in all of those appointments way in advance and not have to worry about going back in every time.
You can do it as a provider. The client doesn't have to do it.
Yeah, I've done it through the phone, the
online you're able to too.
I mean, one major issue we have at the clinic is, we have a 50% ratio of people that are Medicaid and Medicaid transportation, and calling in is 15, 20 minutes, and we have people that abuse it, so then we have that issue, so that takes an additional, time in order, and then we have 2 phones at the front desk and 2 receptionists, so it's not really a feasible option to sit on the phone.
Yeah, absolutely.
One of the issues I run into, I know I don't want to say there's no lot for Medicaid, but there's usually just Medicaid transportation and, Medicare recipients who I feel like they need it just a little bit more. They don't have that. So, just what I devised is just for Albany County, unfortunately. I have a grant with Catholic Charities where I've been kind of utilizing that grant to purchase Starbus passes for those individuals who have Medicare and don't have transportation to their medical buses. And luckily, even if they live in Albany and they have to go to Amsterdam, PDPA buses, the Starbus will take them out there. So kind of just purchasing Starbus passes for those individuals who just have Medicare. Or another resource, Band-Aid.
A couple things we're talking about social determinants of health health and transportation. So CDTA, HCDI just had a in-service with CDTA, and there are so many programs that CDTA offers that I was not even aware of. There's some stipulations and some rules around each, but again, that's contact information I can get you as well. I highly recommend. I mean, they have trainers that will literally get on the bus with you. You know, you can schedule an appointment, start at point A, point B, and if it's to go, I don't know, even if it's to the library or to a support class at the library for like a chronic condition or something. They'll go a week in advance to get you ready a couple times. You go through it so that, you know, so there's definitely education out there. We talk about, you know, something that was up there about networking opportunities. And I've been attending more and more networking opportunities, and there's so much out there. The circulation, I don't know who's familiar with circulation, okay? So it is a transportation platform where you can coordinate transportation, and we have rolled this out. When I say we, I mean Benny, with Alliance for Better Health, our neighboring PPS, to provide transportation to non-medical appointments to address social determinants of health, so really those basic needs, benefits navigation, food, shelter. We're in our pilot phase right now, and we've been training some of our partners, but again, if we get at some of those basic needs, and you know, people have housing, people have food, which is usually high on their agenda as opposed to seeing a PCP, it will definitely help, you know, close that gap and strengthen the clinical and community relationship. You know, it'll be more of a bridge. So that's another, you know, asset that luckily we've been able to adopt for our PPS.
Great. So care coordination across service providers. So you see a PCP, a specialist, you know, you might be linked to a health home, you may be linked to multiple care management agencies, depending, you know, wherever the case may be. But one of the biggest things, I think one of this slide is really ensuring that, you know, truly the lack of communication can lead to a bunch of things, like unmet needs, disjointed efforts, duplication of services, things of that nature. So we can prevent some of those things from happening, you know, if we have the appropriate consents and releases in place. That's one of the biggest barriers that we see, is that we don't have releases to talk to you all about our members, your patients. So getting that consent signed, you know, making sure that we have all those in place, and getting it right at the forefront and explaining to members or your patients on, you know, why you're getting those releases. It's really to coordinate all your care, makes life a little bit easier for them as well, and, you know, for some of these reasons, to prevent from happening. So certainly the next slide is a example of the New York State consent form that can be utilized, especially with certain conditions, substance abuse, or mental health disorders, requires some additional consent on top of just maybe some of the general consents that are out there. So this is an example of a form that can be used for that. But yeah, consent is important, you know, to protect their PHI, their confidentiality. You want to make sure you get everything in place.
Should we be gathering those for, I mean, all of our patients that have your insurance up front? I mean, is that something you would recommend?
If we're paying for the service, per se, so if you're billing an estimated claim to us, we don't require consent to speak with you as a provider.
Right.
So I would say, you know, and for those instances, no. But if you're looking at maybe, not for any provider, so really no.
So it doesn't really
apply to you.
Okay.
The care management agencies, some of the community agencies, those are really where you need those consents in place. You know, if you're participating with CDPHP, we don't need a release to talk with a provider, but community agency, we would. Importance of post-hospital follow-up. So one of the biggest things is, you go into the hospital, you want to make sure that the time between that discharge from the hospital and their follow-up appointment is not a long distance. Our recommendation is 7 days, although we know it's not always feasible. You want to be seen by your PCP, or you know, if you're going in for a particular reason and you're being told to follow up with a specialist, your PCP may not want to see you, but we encourage people to, you know, let their PCP know that they were inpatient in the hospital. This is what took place. Here's my follow-up plan, and let them determine if they want to see you or not. Making sure that you've got the right referrals for care management for clients, you know, with chronic conditions or significant needs. Making sure that people are linked to the appropriate resources upon discharge. And then really making sure that members and our patients understand the role of our non-clinical staff versus our clinical staff. Who does what? I think that's the biggest thing. You know, to your point, there's so many, you know, cooks in the kitchen for one person. You know, one person can be talking to 6 different people in all reality. So trying to really, you know, maybe funnel through one person. we see it with our own programs, a lot of overlapping. So really making sure that people know who to call and for what reasons and when to call them. And really breaking it down to that level. Next slide is a case example. So this is John. He's got a diagnosis of poorly controlled diabetes. He's got a lack of knowledge regarding his diabetes testing and how frequently he should be doing it. Some health literacy issues, understanding the information that was given to him. Transportation challenges. He's been to the ER a lot of times for blood sugars. And then limited access to his PCP due to location. So, what are we doing? What are the interventions and outcomes that we've done to actually assist those things? Offer diabetes education specific to the member's learning needs. So really, that one-size-fits-all model doesn't work. Really trying to find out where they're at, what do they want to work on. Particularly around diabetes, if you're supposed to be testing 4 times a day and they're testing 0, start off at 1 time a day, 2 times a day, and work up and, really getting them to understand why they need to test their blood sugar, the importance of it, what does it all mean on the back end. Medical answering service, we all know that's sometimes challenging to navigate. Giving members the tools to know what questions to ask or what to say to get what they actually need. Because I don't think particularly MAS is prompting members or patients with asking additional questions on what's going on. They're looking for a ride and that's what they're asking for, but if you need a cab or you need a particular mode of transportation, you gotta let those needs be known up front so you get the right transportation. Not always easy, but certainly empowering them to do that. The assist member with making the right PCP choice. Arifa mentioned it earlier, but really having that PCP that you're comfortable with. If you're not comfortable with somebody, there's always another PCP. Yeah, it's gonna take you another 6 to 8 weeks to maybe get in with that PCP, but don't stick with a PCP simply because that was the one you could get into. It's got to be a good fit because you've got to be comfortable. You've got to be able to stop them and say, hey, I got more questions, or I don't really understand what you said. And then develop the member-centered plan for the diabetes testing. So really working up to that, 4 times a day or whatever the case may be. And truly the outcomes, you've got established PCP, hopefully, in the community setting that, will help the member and know their unique needs. You've established the transportation, you've got your blood sugars testing and performance, they're performed and you're ultimately seeing improved breathing. So hopefully putting all this together and giving them the tools and resources to get from point A to B, to get the care that they need and understand the care that they've been given, and what they need to do out in the community and for self-management, truly can give us the positive outcomes.
So as we wrap up the presentation, based on everything that we've discussed, we wanted to pose to you guys, how would you respond to some of these common pushbacks that we will sometimes get from our patients and clients? So for the first one, you're taking away my right to use the ER. How would you respond to that?
Actually, we're giving you an opportunity to get more cohesive care, better quality care with people who know you and are familiar with your case.
Right. And we're not necessarily taking away anyone's rights. They have the right to.
We're trying to save you from sitting, waiting.
Right.
Exactly.
Something better.
Yeah.
Exactly.
Quicker access to care.
Exactly. This one I get all the time, the ER is closer than my doctor's.
Could I just offer,
absolutely.
I think the biggest difference between emergent care and primary care is that emergent care stops crises. It is not set up to establish a treatment plan.
Mm-hmm.
So when you're getting care there, you're getting something to stop that's a problem, but you're not on a path to health. You're just putting out fires. And I would advocate for. I think that's an important distinction.
Right, and it's a great message. I mean, essentially, it's a Band-Aid, or you are putting out the fire at the emergency room. So the long-term plan and making sure people understand that.
And you always say at the bottom, follow up in 3 days with your PCP. I mean, that's all, it's right there.
The ER is closer than my doctor's office?
Probably would offer help in trying to find a doctor that's closer in location.
Yeah, but you'll spend 3 hours or 4 hours in the ER, so in reality.
That's exactly how I
phrase it. Maybe a little further, but it's gonna be a lot less time.
That's exactly how I phrase it. The doctor's office is booking out too far.
And that's the problem.
They need a new doctor.
Because our population is, I mean, it's great to say it's like long-term wellness and all that, we can say that all we want, but unfortunately, a lot of times our clients get stuck in, everything is immediate for them, it's in it's the now. And so, they wanna be seen now, they gotta, when they got pain, they don't wanna wait till a week from Thursday.
Yep, what we've, recently started doing was we formed a partnership with Whitney Young to actually hold slots for CDPHP members, because normally they are booking out several months in advance, for new patient appointments, or for just physicals for established appointments. And so we're trying to remove that same barrier that, you know, if I want to be seen for something, or a sick visit, or a new patient appointment, I don't want to wait several months in advance for that. So definitely exploring what those options are is significant. And then this is the one I explained earlier, that I'm healthy, I know my body, I'm in a PCP, right? So going to the doctor is not just for sick people. It's really about that proactive versus reactive. And sometimes I'll ask someone, and I'll say, okay, if I want to prevent something, what does that mean? And then they'll say, well, it means you want to stop something from happening, right? So I say, okay, well, that's what preventative care is. It's really about stopping something from getting worse, or stopping something significant from happening to you. So really, it's about trying to rephrase things sometimes and break them down in a different way, so that the patients and clients can understand it.
Yes, I'm just curious, is there, because I mean, I know people frequently, at least in our area, they're using the 2 urgent care or 3 urgent care facilities that are in Greene County, and it seems like they're using that more than a primary care office because of availability and you know, after hours, or people trying to work or have kids in school, and, you know, by the time they get home, the primary care is already closed. And I mean, I can say even for myself, my primary care is open until 4:30. I work 8:30 to 4:30. They open at 8. I'm not going to make it to work. They won't even do a flu shot on my lunch hour. You have to schedule it between 9 and 11. So, like, I mean, it is, like, and that's the primary care office that CMH is offering. Like, I go to CMH as one of theirs. So that's a hospital system offering me, a working person, limited availability. So, obviously, my first thing is, okay, I guess I'm going to urgent care if I have a cold or I have some, you know, silly symptoms like that. So I know I'm costing my insurance more money. So is there any, like, I mean, you know, I feel like we have to, in this changing healthcare, if you want these doctors to do more, I mean, they need to be incentivized. You need to motivate. You need to financially give them a reason to want to stay open later and do more for their clients.
There was at one point, about 4 years ago, financial incentives from both CDPHP and Fidelis for the primary care offices to have a certain number of same-day sick slots, walk-in urgent hours between a certain amount of time. So while that particular primary care office may not do that, the office upstairs has the urgent walk-in hours. So I don't know if there's still that financial incentive, but without it, no, people are not going to come in at 7 o'clock in the morning to see patients.
So we have what's called enhanced primary care, which Chris probably was more.
We're kind of a value-based system, a payment system, really paying providers for their performance. So it's really making sure members are getting the preventive care they need, or getting the urgent care they need to be seen. We're creating, you know, a model where we're truly paying for providers for their performance. So we certainly could take that back to them globally to look at as a provider, you know, access issue. You're absolutely right. Same thing with my PCP at 8 to 4:30. You know, you're working. So how do you get in there? Especially when you have even limited.
We have access to sick time. People working at Hester, Starbucks, they have to lose pay.
Right.
Yeah. You're right.
So I agree that access issue is challenging.
And that's a good example too of us like trying to be a model for other organizations, because we recently, I think it's been like a couple weeks ago, we embedded a policy for our staff to have time available in their paid time off to go to mammograms or cancer screening appointments instead of taking away from their own. Yep. So just trying to encourage more places to do that.
I'm just, like I said, I think it's just that we're educated, we're health literate, we understand it, and it's difficult for us. So what does that mean for somebody that's schizophrenic, bipolar? I mean, the minute they're told that they can't come in, or they, you know, they need to schedule on Tuesdays from 9 to 11 to get their flu shot, they're going to say, forget it, fucking that, you know? I got something else going on that day, so.
Right.
I mean, access to care, I think, is a major issue, and like I said, I don't expect anybody to do it for nothing, but, you know, with more expectation and more legislation and more, you know, documentation needed, I mean, there needs to be some sort of correlation between incentivizing that, so.
And then finally, you know, for some of you all, this may have been a review, but just, we wanted to ask if there was anything from this presentation that you feel like you could take back to your organization, at all? Or if you guys found it helpful, or anything that you learned today that you wanted to share?
I think that the in-service option is a great opportunity for providers to have, you know, face-to-face discussions about these types of things, especially in our realm.
And then are there any comments or feedback, questions, anything at all?
Yeah, I have a comment, after this. So, thank you, CDPHP, for coming and doing this, and I think there was a lot of good points made in the room today, which is always great. So for us, we have a performance activity tied to this, so that you'll get credit for it. So one of the things we are asking that you do, there's gonna be an attestation that everybody will see, that goes out to everyone, is there's just a list of kind of what you would adopt, or what you would bring back. So I think that there's a lot of good things, and I don't want people to get too tied up specifically into things like if health tracker's on there and you're like, well, we're not gonna use health tracker, we can't. But again, I feel that you can certainly tailor this information, so it doesn't have to be specifically, we're gonna hand these out. But we would like to know what people are using. I think that the stoplight is another good example, and I know Mercedes, they use it already, so you would check the box that you're using that. But to really, what we're using to promote, to keep individuals out of the ED if it's not necessary, and just educating them to let them know that there's other options, because again, like Rita said, sometimes people just don't know what they don't know. And I think we, as ambassadors of healthcare in the community, kind of, have been charged with making sure that we educate them to the best that we can. And again, we're gonna tell people and highly recommend and make suggestions, things, and, you know, hopefully some of it sticks, some will stick, some won't, but again, put the information out there. I always think about it as like I'm talking to a child. There's sometimes you don't know that they're listening, but then when they do something, you're like, oh, wow. And I know that you shared a personal experience, and I've had personal experiences too with family members that just the littlest thing that you don't think, wow, I never thought about that. It helps. It really does help for some people, and just kind of meeting people where they're at. I try to use the phone as much as possible for people now. It seems like everybody has a cell phone. So I have family members who go to the doctors, and they're not bringing all those bottles. I say take pictures. Just take pictures of your labels. You go to the doctor. Those little things help. For individuals who have to take several medications, you brush it twice a day, not necessarily remembering. Set a timer. Might be Mickey Mouse. You can say, hey, it's 1:27, and once you hear that, or 11:27, whatever, that's how you know. So it's the little things. So that's it. So that's important, and
I would never honestly thought taking pictures of your prescription bottles versus bringing that whole bag in, right? I mean,
We had a client who had a literal duffel bag full of prescriptions.
take pictures of them.
Yeah, so I was like, we're gonna need you to not bring that with you everywhere, we're just gonna take pictures.
Yeah, I mean, everybody carries their phone. I mean, I mean, a simple as that.
You're welcome.
Thank you, appreciate that.
You know, I'm
That's good.
a nurse and I have all my vitamins and stuff. I put all of them together, take one snapshot, and then when I go to the doctor's office, rather than trying to remember, you know, how much vitamin C do I, you know. It's great, it's a great idea.
I would recommend they bring the whole bag in once, because that's when you find out that they mix their Lasix with their Carvedal. And they mix this with this. And
Or they
you
haven't
wouldn't
had it
believe
filled in
it till
a
you see it
year.
at home, but really,
Yeah,
that's
right.
where it's
And
Like,
and
you want to go out.
the expired meds are in there.
A whole stockpile of antibiotics, just in case.
Yeah, that expired 7 years ago.
I use examples also when educating. Like, I give the client an example of someone that didn't engage in the primary care, didn't realize, the example is that the individual got cut at work, self-employed, no insurance, bottom of his foot, went to the urgent care, got it stitched, that's why I wouldn't. And he lost a portion of his foot. And Albany Med called me to come over and get him health insurance at the time. So I think, I mean, it's kind of a scare tactic, but it's reality, and it does make them stop and think a little bit, like, wow, you know, she's right. Like, I have underlying issues that could prevent me even at ED or an urgent care, you know, and then I go deeper and explain, when you go to the urgent care, they don't take your blood. They don't send you to get your lab work to see if you have diabetes or cholesterol or this or that, and, you know, just keep kind of going on that note of it. So, and I've had some success.
Cause and effect.
Yeah, go.
And consequences. I personally feel that's the best way to teach somebody, because we do. I mean, even during this presentation, we heard should, have to. Nobody really has to do anything. Even on some of our stuff, it says only. It's not only. So just those words are very loaded, but if we can highly recommend and say, okay, it might be a good idea for you to, because again, this could happen. There's a consequence for you.
It's more on that note of, I understand you have the immediate need.
Right,
you know,
right.
And that's what you're looking, but that's exactly what you're gonna get. You know? When you go to urgent care, they don't care about your history, they don't, you know, are you allergic to something, medication? That's usually the biggest question that they ask for history, you know. If you say, I don't know if I have diabetes, or I don't know if I have cholesterol, they don't check you, or they stitch you up.
I really appreciate it. If I could build on that, all benefits, no downside, no what you should, what you shouldn't. It's all what's in it for you. And I love your example, because to me the big difference between the ED and primary care is ED treats symptoms, primary care treats symptoms and causes. You know, you can treat all the symptoms you want, you don't get to the underlying cause. You're not going to solve the problem. You cannot solve a chronic disease in an emergent setting. But if that's where you go for care, you will continue to have emergencies. So I think we need more of this kind of consumer-centric messaging, things you can remember. You know, we're in a social media world that means everything is short, people's attention span is short, what they read is short. As soon as it's a paragraph, they're not reading it.
Check out.
Yeah, you know, so
Grade level.
you need something that people can remember. The ED, they don't know you. The PCP, they know you. Who do you want to care for you? ED puts out fires. PCP creates a plan to be healthy. You know, what do you want? You want to have fires? You want to be healthy? No, but things like, you know, it has to be very transactional, what's in it for you.
But PCP's gotta be, they need to step up to the plate, quite honestly, as far as, you know, just, you call them and the first thing they say, if this is an emergency, go to the emergency room. Yeah, certainly if it's chest pain and things like that, that's definite. But I think if they kind of also massage this issue about, we are where you need to go, and you need to avoid going to the ER, and really do some education as possible, or encouragement, and not shuffle people off. Because I think a lot of times it is, you call off of this for appointment, same day appointments, whatever, they'll say, well, for an emergency, go to the ER. And I think the primary care office often will shuffle clients to the ER.
Yeah.
And I think really working with them.
With the whole, like you missed one appointment. Well, did you miss that because of childcare? Did you miss that because of transportation? Or, why did you come to your appointment? Well, I was standing in line at the food pantry, you know, like, not just shutting that out, facing those barriers with them, like.
A lot of what we said today is about accessibility. People want, whether it's transportation or whatever, they want their care to be accessible for them when they want it. And that really comes from a big part with primary care. We can, as case managers, whatever, we can run our legs off trying to redirect clients all the time, but those doors have to be open.
Right.
Thank you so much, and CDPHP can help with that, because we're talking about supply and demand. You can push the demand to go where you want, all you want, but they're responding to the supply. When the PCP office is saying, no, you have to play by our rules, or if they're confusing, they don't do any onboarding, so you don't even know how to get your care the way optimally, then the marketplace adjusts, and they go to where they can get care in a way that they understand, in a way that's convenient to them, just like they would with any other service. So that supply side needs your support and encouragement to be more receptive to consumers.
I had a quick question. I don't know if anybody attended. There was a value-based, district training that was in Glens Falls at the Queensbury Hotel, and they brought up the Wealthy app. And is that something that CDPHP is willing? I mean, they were present for it. You were part of the presentation, but there's this app about medication adherence. And just curious, because I know like one thing that didn't come up was the behavioral health and mental health population. A lot of their ED visits is because they're not taking their medication as needed, and they're going in. I mean, we've had how many pickup orders, and it's Wednesday. We have 2 already.
2 on 1 person.
2 on 1 person. So I mean, just from that standpoint, it's actually it's a reimbursement. It's an app that the people download. They take pictures, the pill in their hand. They note that they took the pill that day, and they get paid for it.
Oh, wow.
Yeah.
Yes, there's a financial
incentive for them.
They go buy drugs.
That idea.
Yeah, and I mean, I don't necessarily know that the substance abuse people might use that the wrong way, but hey, at least we know they're taking their mental health meds appropriately, and for people that are Medicaid users, they're low income. So how about a couple $100 for the year to make sure you took your medicine? I mean, it seems like it's
called Wealthy?
It's the Wealth. I can give you the app, because I actually watched the demo on it when I got back from it. It's WELLTH. Better patient outcomes with behavioral health.
The CDPHP still do the life points thing?
We do for commercial members, yeah.
But not
for
Medicaid.
For Medicaid members, certain ones are qualified for incentives based on what they're due or overdue for. For women, they do get incentives for mammograms, cervical cancer screenings, colorectal cancer screenings as well too. So it depends on what they're due for.
What is that called again?
Which one? This one?
That's yours.
Oh, okay.
Yours, the one that you just mentioned.
Life points. Yep. And we did have a comment as well.
Oh, no, I just was feedback on the encouraging clients to go to their PCP and saying, I know a lot of us are busy and have a lot on our agenda, but when available, offering to go to the appointment with them, saying, hey, let me set up this appointment for you, and I'll meet you there.
Especially when they're there.
I definitely want to take away. Yeah, I think that's huge, because it's not enough support with our clients. So
and they're going through so much, and so when they have that one person there to meet them to do something like that, particularly if it's some sort of cancer screening that they're going to be getting done, it's scary, and so to have that support is
important. And then asking those questions, or just piggybacking on ideas where those questions come from. Sometimes being there, present in the appointment is helpful, or even in a waiting room.
Absolutely. Thank you guys so much.
Do we have your contact information? I don't think it's here. Oh, that would be great.
I actually don't have any copies with me, but I can get that.
Your website is great. 27 years of home care, finally everything's in one place, and no one knows that comes from it. Fantastic.